Welcome to all. I request every participants to turn on their video during their respective presentations. Uh, I would like to welcome both the judges who have dedicated their time for this event. First, I would like to tell about the instructions. Everyone have to present their PowerPoint presentation only for 5 minutes. After that, our in charges will tell that the time is over. So please stick to the time. And while you are presenting, there will be a discussion in which both the judges will be asking some questions and you will be answering it. So likewise, yesterday I've sent the list by in that order only everyone is going to be presenting. So let's start. Good evening and warm welcome to all. Myself Motisha, a final year student from Mada Medical College, and I feel immense pleasure in hosting this event. I would like to quote a Tirukural regarding research, which says, பிழைத்துணர்ந்தும் பேதைமை சொல்லாது இழைத்துணர்ந்து தீண்டிய கேள்வி அவர், which says, நுண்ணியதாக ஆராய்ந்து அறிந்து கேள்வி ஞானத்தால் நிறைந்தவர் பிழைபட உணர்ந்த போதும் அறிவற்ற சொற்களை சொல்ல மாட்டார். I would like to welcome the 10 finalists from various colleges who have dedicated by making this event a grand success, and two eminent judges, and the most importantly, the spectators who all have gathered here, allotting their time in the busiest Sunday evening for the event Exploro, the research paper presentation, as a part of ADRENERGIX 2.0 conducted by SNOTN. Research is very important not only in medical field but also in our day-to-day life. We keep experimenting things every day and find out based on the outcome whether it's good or not. Research makes us to find newer approaches which make our life easier day by day. When it comes to the medical field, research can change the approach to a clinical condition, making procedures easier both for the physician as well as for the patient. So now I would like to welcome the judges for this event. First, I would like to welcome Dr. MP Brinda ma'am, currently working as Professor of Pathology in Mada Medical College. Ma'am has completed her UG in IIT Perundurai Medical College and PG MD Pathology in Kottayam Medical College. She has also done her DNB Pathology and PhD Pathology. Ma'am has working experience of 11 years in pathology field. To tell about her interest in research, she had published about 22 papers in both national and international journals. Ma'am has got many awards for her research presentation. Beyond all, she is an enthusiastic speaker and teaches concepts of pathology in an innovative way. I must mention that it's because of ma'am I could get good marks in pathology. Apart from academics, she is such a down to earth person. Apart from being the best teacher, I usually see her as my best friend. I feel glad to welcome you, ma'am. Next, I would like to call upon Balhari to welcome our second judge, Dr. Chitra ma'am.
Mhm. Good evening and warm welcome to all. I am Balagariran, second year MBBS, Madras Medical College. Here I would like to invite our next judge, Professor Dr. Chitraman, MD in Community Medicine in the Institute of Community Medicine, Madras Medical College, Chennai. In addition to her 20 years of government service, she has numerous national and international journal publications to her credit. She is a national and state level trainer for several public health programs. She was a former member of the Standing Academy at Medical University, as well as a former planning expert in NRHM SHS, Tamil Nadu. We are really fortunate to have such a knowledgeable and experienced judges for our competition, and we are sure that their feedback will be invaluable to all of the participants. So, without further ado, let's get started.
I would like to call upon Dr. Brinda ma'am to talk a few words. Ma'am, your voice is not audible, ma'am.
I am Dr. Brenda. Hello, all. All the participants, good luck for you. And I wish us the participants. And here it is a research program to judge the research my methodologies and the research paper presentation. They called me, they invited me. I I'm very much grateful to the participants and the organizers, and especially Miss Motisha. And she is one of my best friend, and it is it is giving me immense pleasure to participate in this SNO program as students are conducting this. I'm very much eager to see what they are going to present. Thank you.
Thank you for your inspiring words, ma'am. Next, I would like to call upon Dr. Chitra ma'am to give a few words.
Good evening, all of you, and very pleased to be a part of this scientific session today evening. And I congratulate all organizers, especially constant touch, and I look forward to have a wonderful scientific session this evening. Clarity, can you tell us, the judges and the participants, on how we are going to judge them? And what would be the end result? Are we going to give prizes? If yes, how many? And that kind of information to all the 10 here. Thank you.
Ma'am, I'll talk about this at the end, ma'am, regarding prices and all. Thank you for your inspiring words, ma'am. So we'll
How
start.
do we? No. How do we mark them? Give them. I mean, for all the 10 finalists, we give them our individual marks and send it to you, and you will then finalize. Is that
Yes,
right?
ma'am. Yes, ma'am. You both will give separate marks, then we'll sum up and tell the results, ma'am.
Okay. So maybe then each of us will score them out of 20.
Yes, ma'am.
Each
Out
part
of 20. Yes, ma'am.
out of 20. Okay.
Okay, ma'am. Thank you, ma'am. So we'll start with the session. Our first participant is Umastri Sundar Raja from Government Omadurar Medical College. She's doing her third year MBBS.
Am I audible?
Yes, you're audible.
Am I audible? Thank you so much. Good evening, respected judges and fellow delegates. I am Umashri Sundaraju, a pre-final year MBBS student, here to present the research on developing and evaluating the risk factor scoring scale for gastroesophageal reflux disease. I would like to quote, "Prevention is better than cure," before I proceed with my presentation. Next slide. As defined by the World next slide. Can the slide be changed?
Motisha, are you presenting the screen? Motisha? I think you can go ahead, ma'am.
Ma'am, yes, ma'am.
Okay. As defined by the World As defined by the World Health Organization, GRD refers to a troublesome symptoms or complication that occurs due to a retrograde flow of gastric contents into esophagus. As reported by the survey conducted by Indian Society of Gastroenterology, the prevalence of GRD in India ranges from 7.6% to 30%, and 784 million cases of GRD are reported globally.
Should I change the slide?
I think her voice is muted. I couldn't hear her voice.
Am I audible now, ma'am?
Yes, you're audible.
As defined by the World Health Organization, GRD refers to troublesome symptoms or complications that occurs due to retrograde flow of gastric contents into the esophagus, which is the major cause of concern due to the complications leading to significant morbidity. As reported by the survey conducted by the Indian Society of Gastroenterology, the prevalence of GRD in India ranges from 7.6% to 30%, and 784 million cases of GRD reported globally. Our literature reveals that many validated symptom-based scoring scales like self-administered validated questionnaire like GRDQ for diagnosing GRD, but we found no scoring system that could predict the risk of GRD. There are proven risk factors of GRD are poor quality and quantity of sleep, older and obese individuals, smokers, alcoholics, stressed individuals, poor nutritional habits, and inadequate diet fibers. Third slide. The aim of our study is to create a validated questionnaire tool that can be used to assess the association between the risk factors, exposure, and the risk of developing the disease. Third slide, please. Using this data, we intend to create a validated scoring scale to predict the risk of developing GRD. Next slide. Am I audible?
Yes, you are audible.
Yes, you are audible. Go ahead.
Slide 4, please. We created a structured and close-ended questionnaire with a matrix of multiple choice questions. It was divided into 6 modules with a total of 45 questions. These questions were modified and adopted from already existing validated pre-existing questionnaires in literature. The scoring system is also adopted from the scores each component. The sample size was calculated based on the Kelsey et al. Formula, and we have 107 cases and 107 controls. Next slide. We obtained Institution Ethics Committee approval and designed a case control study. After obtaining a written consent, 60 participants were recruited from the OPD of Department of Surgery and grouped as case. A case is defined as any individual diagnosed with a GRD as per ACG guidelines and was recruited by consecutive sample method. A control was either a healthy volunteer or an individual whose upper GI endoscopic findings were normal and they were recruited by convenience sampling. We excluded 18 years and the patients who do not consent to be a part of the study and the patient suffering from peptic ulcer disease and hiatal hernia. Next slide. We proceeded by interviewing the patients and then administered the questionnaire to collect the following data. In Module 1, age and BMI is collected, and the PACUS for smoking, audit score for alcoholism, and PSQI score for sleep and quality, and the fiber scan score for the fiber content, and the PSS4 score for the stress. This data was exported into the Microsoft Excel and exported to Jamovi software for statistic analysis.
The slide is not moving. Who is taking care of the slide presentation?
Motisha.
Now we have.
Before results, I would like to discuss about the statistic analysis. We convert all the continuous variables into categorical variables to plot the contingency table between each factor and the disease status. We qualitatively find the association association by two-tailed Fisher exact test and quantitatively by Cramer V value, which is a measure of effect size. We then create a multivariate logistic regression model based on the GRE dependent variable and the risk factor as an independent variable using the regression coefficient based on the scoring algorithm described by Hemal Kumar B. Mehta. We assigned weights to each E factor and created a scoring scale. The scale was simplified and optimized for easy assessment and evaluated prospectively, and the ROC score was plotted with the scores. The validity of the questionnaire was tested by the Cronbach alpha after reversing the scoring of diet. Now let's discuss let's discuss the results. Our study consists of a total 214 patients, and we have combined them into multivariate cohorts. The table here shows the association between the GRD and each factor quantitatively and qualitatively, and the Fisher exact Gamma V value respectively. Next slide. Ma'am, next slide, please.
Time's up, ma'am.
You can just show us the slides. Just keep moving the slides, Motisha.
The logistic regression equations were created and the
Ma'am, time's up, ma'am.
the scoring indicating good reliability and curve obtained with the 96 sensitivity. And the cutoff point chosen is 30 points based on that index. Next slide, please. I would like to conclude that we are presenting the GRD risk scoring scale. It can be used in the population for assessing the risk of developing GRD, which is the primary prevention of GRD. The GRSS score lies between 0 to 29, and the highest score translates to increased risk of developing GRD and to prevent GRD. Thank you, ma'am.
Good evening, ma'am. Is the
Good
survey
evening, ma'am.
question is already available and online, or you created the scoring? That question is scoring.
Ma'am, the questions were obtained from standard questionnaires from that were already present in the literature review, and we have combined them. And we are yet to publish it. We are going to publish it in the Lancet Gastroenterology journals, ma'am. So it's yet to come online.
Okay. So who had done for the statistical analysis for you, or you have done?
Ma'am, along with my team and with the help of our community medicine department, we have done the statistics.
Okay. So how did you obtain the control? Because nobody is willing to do the endoscopy with the normal findings, isn't it? So how did you
Yes, ma'am.
end up with the controls and all?
Ma'am, before our study, we did a pilot study where the clinical guidelines for GRD diagnosis is compared to the gold standard endoscopy. The clinical guidelines was from ACG guidelines, which was standard and is followed in almost every OPD. And we also got the sensitivity as 91.67% and the specificity of 90%, ma'am. So hence we use the clinical guidelines for the GRD, ma'am.
Okay. Ma'am, over to you, ma'am. Chitra, ma'am.
Okay, ma'am. Umashri, the
Yes,
first
ma'am.
question is, what is the need for such a new tool now?
Ma'am, can you repeat the question, ma'am?
What is the use for developing a new? We have already tools to predict GERD, to diagnose GERD.
Ma'am, there are existing tools that are system based. Ma'am, literature review tools for risk
Your voice
it
is not
based
clear.
on because of this tool. Ma'am, there are existing tools that are symptom based, ma'am. We have GAAS tool, the reflex disease questionnaire, which all are based on the symptoms. But this is based on the risk factors. The risk factors are already proven, ma'am. So this can help in the primary prevention and by based on the lifestyle modification.
Okay. And what are the things that you took for defining the cases?
Ma'am, the cases were the patients who are from um, endoscopy, like who have based on ACG guidelines and the endoscopy, the patients who are diagnosed with GRT, ma'am, that are present to the surgery OPD.
So you said something about fibroscan.
Yes, ma'am. That is a scoring system, ma'am. That's a questionnaire for the questionnaire.
No, you did the fibroscan for all individuals.
Ma'am, fibroscan is a questionnaire. The questions were taken into our in our question design, ma'am.
Fibroscan is a questionnaire.
Yes, ma'am.
Okay. Okay, no more questions.
Thank you, ma'am.
Thank you, Ms. Sri. Thank you, ma'am. Next, we'll go for the second presenter, Raj Shah from Baroda Medical College, belonging to there.
Hello, good evening. Is my voice audible?
Yes, it's audible.
Is my screen visible?
No.
Yes.
Yes, it's visible now.
It's visible? Okay. So I hope the timer starts now. And will you please give me 1 minute warning if it is possible?
Sure.
Yeah. Okay. Thank you. So good evening, respected judges and my dear friends. My name is Rasha, and I am here to present my paper on the prevalence of postpartum tribal mothers of newborn admitted in NICU of Central Gujarat and its relationship with breastfeeding pattern. Postpartum depression, that is a depression seen in mothers within 6 months of delivery, is a widely researched topic. And studies have shown that NICU stress causes high PPD rates and indeed to lower breastfeeding outcome. But no study has been done in tribal maternal mental health sector. And considering the various positive implications which we can get uh, to answer after filling the knowledge gap, we aim to do this study with the following objectives: determine the prevalence of postpartum depression in tribal mothers, determine the breastfeeding pattern of their infant, correlate and deriving effect of mental health of the mother on her infant's feeding pattern. This was a cross-sectional analytical study conducted in NICU of tertiary care hospital at Vadodara, Gujarat for 1.5 months with a total sample size of 107. We included tribal mothers of all preterm and term infants admitted to NICU for any reason for greater than 7 days, while excluding the diet in which the breastfeeding could not be possible. After approval of ethics committee, the data collection was done through face-to-face interviews with a structured pro forma for which daily 2 to 3 mothers were sampled. The structured pro forma consisted of 4 sections. Out of which the important one was the Gujarati validated version, widely used scale worldwide for PPD screening. Doctor records were checked for confirmation of the information, and psychiatric referral was done for positively screened mothers. Of the 107 mothers, the mean age was found to be 23.88 years. Majority were from tribal districts of Gujarat and Madhya Pradesh, were literate, were from joint family, and had no past history of abortion or antenatal illness. Of the babies, 58 were male, 49 were female, and majority were preterm and admitted in the NICU on the first day of life. As for the PPD prevalence, we found it to be 4.67%, which is pretty less compared to all the estimates in and out of NICU. To delve deeper into this, we analyzed the data and found that antenatal illness present in the mothers, less gestational age, and uninitiated breastfeeding were significant risk factors associated. Also, qualitative observations were made which showed that sufficient support from family as well as other mothers and nurses in the ward was found was for the mothers, which could have led to the less prevalence seen here. Breastfeeding pattern. The secretion was seen in all the mothers within the first week postpartum, but breastfeeding was initiated only in 30% of babies. Others were still on IG or Katori spoon feeding. Exclusive breastfeeding was seen to be 39.25%, which is comparable with Turkish study by Surmeli Ana et al. At 42.9%, and is quite reasonable considering the morbidity of child. There is no statistically significant relation found between PPD and breastfeeding pattern, though we can see clinically that mothers, that is 80% were having mixed fed babies. This could be confirmed in later studies by using a larger sample size, which leads to our strengths and limitations. The various strengths were my quality control measures used, ethical consideration, as well as the recommendations given in the literature for future postpartum depression studies for more comparable results at the worldwide level. Main limitations were small sample size, unicentric design, and majorly the iceberg phenomena that only the literate mothers would have brought the babies to the hospital. There would be a large uh, population out there which could not be seen by us. Hence, we conclude that the tribal mothers have lower postpartum depression prevalence, which may be due to intrinsic resilience or extensive social support. Possible risk factors for the PPD found were antenatal illness, low gestational age, and delayed breastfeeding initiation. Early secretion initiation and delayed breastfeeding initiation was seen in the mothers here. Reasonable EBF percentage was found with respect to the neonatal morbidity. Overall, no effect of postpartum depression on breastfeeding pattern of neonate was seen. This study opens a lot of questions which need to be further answered with the help of various departments of medicine, that is obs and gynae, pediatrics, community medicine, and psychiatry, which could be answered with these future recommendations. I would like to acknowledge the supporters of this study. Uh, these are my references, and at the end, I would like to end with a success story in our study, in which we found a lonely mother who had been not taking interest in her baby in the NICU, and hence we did screening of the mother and found to be
Time's
positive.
up.
We referred her to psychiatry. 1 minute remaining.
So only it already done, sir. I already time's up,
Okay,
sir.
okay, yeah. So we found positive results for her. Thank you.
Very good presentation, Alan. Uh,
Thank you, ma'am.
and I need to know two things. You
Yes, ma'am.
had help from psychiatry department, isn't it?
Yes, ma'am.
Okay. And regarding which criteria they have identified this post depression, do you know that?
Criteria. We use DSM-5 criteria,
Okay.
and in the DSM-5 criteria, the postpartum depression is included in peripartum onset depression. Up to 4 weeks, it is there for that. Up
Okay.
to 4 weeks postpartum, the criteria is there for postpartum depression.
Okay. That breastfeeding measurements, everything you got help from Logician also, isn't it?
Sorry, ma'am.
Or you have breastfeeding, that history of breastfeeding and the reduction or normal breastfeeding, you don't know by the PPD with the breastfeeding, isn't it?
Uh, Breastfeeding, yes, it was information was asked from the mother regarding the secretion
Information
initiation.
back from the mother itself. Do you have any
Yes, yes.
questionnaire for that which was circulated for among the mothers?
Uh, Sorry, I didn't get the question.
Do you have any specific questionnaire, say set of questionnaire to ask the mother regarding this history?
Yes, yes. We have questionnaires, but The question is are widely around parameters which were not setting in this study. And in the
Okay.
literature, it is told that you need to determine the variables you need to study before starting the like research. So question is
Okay.
were not setting, so we didn't use that.
Okay. Okay. Over to ma'am.
Mm. Good evening, Viraj. Very good
Good
presentation,
evening.
and you were so professional, like sticking on to the time and the slides and all that were very good. Uh, One question from me is, how did you measure the adequacy of breastfeeding?
Uh, Ma'am, adequacy was not a criteria in our variables. It was mainly secretion in it because each baby is different and its baby's needs are different. So adequacy was not checked here. It was basically data was collected and for secretion initiation, breastfeeding initiation, and if the baby was given mixed feed, formula feed, or just breast milk. That those were the main criteria.
No, but the one of the objectives was to know whether postpartum depression causes a reduction in breast milk, right? That's how I
Yes,
understood.
yes. That was the correlation we needed to find.
Mm.
But like it was adequate or not, we didn't use a criteria for that. We just took the data and like there was no cutoff for adequacy we used.
So I recommend you to do that also so that you get a much better outcome.
Yes, ma'am, sure. We will compare with the other studies and take adequate
Yes.
cutoff.
Yes. Okay. Good. Thank you.
Yeah. Thank you.
Thank you, ma'am. Thank you, Vraj Shah. Next, I would like to welcome Dr. Alhat Mulkarwar from Seth GSMC and Chem Hospital, Mumbai, who's current intern.
Uh, Thank you so much, ma'am. Is my screen visible and my voice audible?
Yes, you're audible.
Okay, I hope my screen is visible.
Yes.
Yeah, so I'd like to start now. Good evening, respected judges. It's an honor to present to you my study which is titled Evaluation of the Role of Jyotishmati or Celestis paniculatus wild seed oil in animal models of alcohol use disorder. Now, today we are well aware that alcoholism is a major public health concern globally as well as in India. It is the most common psychoactive substance to be consumed by Indians, with about 14.6% of the country's population, or 16 crore people, regularly consuming liquor. Now, chronic consumption of alcohol leads to results in disinhibition of the dopaminergic activity, along with upregulation of the NMDA receptor system in the reward pathway, which results in the development of alcohol dependence. The pharmacotherapy of alcohol use disorder currently includes drugs such as naltrexone, acamprosate, topiramate, etc., which are used along with cognitive behavioral therapy. However, high relapse rates and multiple adverse effects reported with these drugs reflects an unmet need for a safer and more efficacious drug for the treatment of the same. Now, Silastus paniculatus or CP, which is commonly known as Jyotishmati, is an Indian medicinal plant which is commonly used in Ayurvedic practice for memory sharpening and cognitive improvement. By virtue of its suspected anti-glutamatergic and anti-dopaminergic activity, it is proposed to have a role in the treatment of alcohol use disorder as well. The objectives of my study were to evaluate the effect of Silastus paniculatus seed oil in animal model of alcohol dependence, to assess its effect as an anti-craving agent, to study its mechanism of action, and evaluate its anxiolytic effect in alcohol withdrawal-induced anxiety. On obtaining permission from the Institutional Animal Ethics Committee, the study was commenced using 144 Swiss albino mice and 48 Wistar rats. The study was then divided into three parts. Now, in part one, the condition place preference model was used to study the effect on alcohol dependence. The CPP apparatus consists of two cuboidal compartments which differ in distinct visual and tactile cues, serving as conditioned stimuli. Swiss albino mice were used in this model. On day one, the preference of mice for either of the two chambers was first determined, and then they were conditioned using alcohol to stay in the non preferred compartment. On day 11, the effect of the test drug to successfully reverse this alcohol associated conditioning was tested. Here we found that each of the CP groups showed comparable results to the standard control group of naltrexone, and they all significantly reduced the time spent in the alcohol preferred compartment as compared to their respective control groups. Celestis paniculatus also showed a dose-dependent response, with the highest dose being the most effective one. Now, coming to part 2, which is the alcohol deprivation effect model to study the anti-craving activity of our drug. Here, Vistar rats were used. They were offered 10% ethanol and water via a 2-bottle choice drinking regimen for 8 consecutive weeks in their home cage, after which they were divided into multiple groups. Now, raclopride, which is a deep dopamine receptor antagonist, and D-cycloserine, which is an NMDA receptor agonist, were administered along with CP seed oil in groups 5 and 6 respectively to find out its mechanism of action. The rats were deprived of for alcohol for 15 consecutive days, and water was the sole fluid available to them, and the test drugs were administered during this phase. At the end of day 15 of the deprivation phase, alcohol was again introduced and its consumption was recorded 60 minutes later. Here it was found that the animals in the CP group consumed significantly less alcohol on reintroduction as compared to the vehicle control group. However, the alcohol intake as well as percentage preference of alcohol was not significantly reduced in those rats which were given raclopride or D-cycloserine along with CP seed oil. Thus, these drugs could successfully reverse the anti-craving effect of our test drug, showing that Celestis paniculatus seed oil acts via the glutamatergic and dopaminergic pathways. Coming to part 3, which is the alcohol withdrawal induced anxiety model. Swiss albino mice were used in this part, and alcohol addiction was induced over 2 weeks using intermittent access to 20% ethanol via a 2-bottle choice drinking paradigm, after which alcohol was then withdrawn. Diazepam was used as a positive control, and the test drugs were administered 3 days post ethanol withdrawal. Now, the elevated plus maze consists of 2 closed and 2 open arms which lie perpendicular to each other. The mouse was placed at the center of the maze and allowed to explore it for a period of 5 minutes. The rodent's natural preference for protected areas, that is the closed arms, is reinforced by anxiety, and thus greater the anxiolytic effect of the drug, more would be the time spent by the mouse in the open arms. Similarly, in the open field test, more the anxiety, more the time spent in the peripheral zone, and greater the anxiolytic effect, more the time spent in the central zone. Here in the elated plus maze as well as the open field test, we found that the animals which were given the test drug spent more time in the central zone, showing greater anxiolytic effect comparable to diazepam. To conclude, Celestis paniculatus showed dose-dependent activity in alcohol dependence model. It showed anti-craving and anxiolytic effects comparable to naltrexone and diazepam, and it acted by the glutamatergic and dopaminergic modulation. And we are currently planning further studies where its effect on neurotransmitter levels in specific regions of the brain, that is the prefrontal cortex, striatum, and midbrain, can be done to understand the molecular level analysis caused by this drug, which will pave the way for future development of this drug as an anti-alcohol use disorder or anti-alcohol addiction. Thank you so much.
Good evening. Very doing very difficult concern and IHCC approval everything. I appreciate your hard work, and I need to know how you calculated the anti-craving and anxiolytic effect in animals. Is there any criteria for that?
Yes, ma'am. So, as I said in my presentation, when we addicted the rats to the alcohol, then we withdrew it for 15 days, and then we divided into groups. When we reintroduced alcohol, the consumption was noted for 60 minutes. Now, the group of animals which were given the test drug consumed significantly less alcohol on reintroduction as compared to the control group. And in for the anxiolytic effect, ma'am, in the elevated plus maze test and the open field test, using a monitor camera, the group of mice which were given the test drug spent a lot of time in the center area or the central zone, which showed that there is more explosive behavior, which is suggestive of an anxiolytic effect. And this was comparable to diazepam, ma'am.
Okay. So you have used one way ANOVA for this to multiple. Why you used that?
Ma'am, because there were multiple groups we were checking, and these were paired. These were paired readings because one reading pre and post, and obviously there were multiple horizontal stratification as well, which made this as the ideal test, one way ANOVA and post hoc Tukey's test. again, this was done using the SPSS software.
Okay. So, any bioinformatics study is planned for this in future to analyze the
Yes,
molecular level?
yes, ma'am. So actually, what actually just today itself I was in the lab again. Now that we have analyzed the behavioral component, now using liquid chromatography on the Bain specimen, we are actually checking the level change, molecular levels, especially amine and glutamate. Once we can exact record this molecular level analysis, that will give fertile ground for starting the phase 0, phase 1, and the further human trials. Because as I said, there is no particular drug yet, which is a gold standard for treatment of all the parameters. It is used in Ayurvedic practice since a long time with no reported side effects in Ayurvedic literature at least. And here too, the only side effect was that it caused a mild esophageal irritation, which is why it is taken with cold milk. So which is why it seems to be a very promising alternative. And once we find this molecular level analysis or using liquid chromatography, we can go ahead with further studies, ma'am.
Okay, thank you, sir. Now over to you.
Thank you.
Good evening. I'll have a very, very interesting presentation, study also. Question is, in Ayurveda, they're currently using this for alcohol dependence individuals?
No, ma'am. Actually, currently in the Ayurvedic practice, it is used very commonly known as Jyotirmati for cognitive improvement and memory enhancement. And also, there are some cases where it has been used for epilepsy. There are some cases where it is used as a very wide spectrum. However, its use even in Ayurveda is not for alcohol use disorder. So now the next step is molecule which is silastrin, and then check its efficacy as an anti-alcohol addiction, because it is shown in previous studies and even in this study that the mechanism of action is glutamate and dopamine, which are the neurotransmitters which play an important role in the reward. That is how we thought that maybe this has an some implement use in alcohol use disorder, but no, it is not currently used for this condition, ma'am.
But it is an approved Ayurvedic medication for the
Yes,
other
ma'am.
conditions that you mentioned.
Yes, ma'am. It is approved for the other conditions, but not for alcohol use disorder, ma'am. It's a
Okay.
very wide spectrum which is used in Ayurveda, even as a memory enhancing agent for daily use. Some people prefer Jyotishmati seed oil every 1 TVSP every day. So that is how it's very widely used, but not for this specific condition, ma'am.
Okay. And you had mentioned about the ethics clearance.
Yes.
It was obtained in 2014.
Yes, ma'am. So this was immediately once I joined MBBS. That is the time when this was conceptualized, and it took a really long time. Again, COVID-19 put a damper on the timeline. But this entire study, as the behavioral model which we did, along with the other molecular level analysis which we are doing right now, this entire model was approved on block for this particular research, ma'am. So the part one we are done with so far, but it's a really, really long study. I'm also working on the operating conditioning model, reward-based model for the same drugs on rats and mice. So it's a very long study, ma'am. It was an 8-year long study protocol itself, which we are working on. So actually, throughout my MBBS, I have been a part of it, and I have been working on some of the other stages, including learning how to use the rats, and I had a special training for that as well. But now, especially in the final year and internship, is where I have these models are actually performed, ma'am.
Okay,
The
good.
products used.
Good. Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you, Alhat Mulkalwar, doctor. Uh, Next, I would like to welcome CR Yogita from Ragas Dental College. She is studying second year.
Good evening, ma'am. Am I audible?
Yes, you're audible.
Sure.
Your slide.
Yeah, 1 minute. Is it visible?
It's visible now.
Am I audible?
Yeah, you are.
Yes. So, good evening to everyone. This is
Your
Yogita.
PPT is not visible.
Sorry?
Your PPT is not visible.
Is it visible now?
No.
If any connective issue, we can move on to the next person. No, later on she can connect and present.
Or else, can I do it for you, Yogita?
Is it now visible or not?
Only the screen is visible. You see whether you can share the choose screening the window.
Okay, 1 second, ma'am.
Yes, now visible. Yogita, your screen is visible. Self and talk.
Thank ma'am.
Yeah.
Yogita, you directly go to their aims and objectives, methodology, and start presenting.
Yeah,
No
ma'am.
need for introduction.
Okay, ma'am. So yeah, we just start with the paper presentation here, Yogita. So we're going to do this presentation on role of conformation changes of collagen in the early diagnosis and advanced treatment of oral submucous fibrosis. So let's move on. So this is the background of this because oral cancer is one of the leading non-communicable diseases in the Indian subcontinent, and more potentially it is a malignant
Yes,
condition.
ma'am, you can go on to your aims and objectives. I said we need not waste time on the introduction.
Okay, ma'am. Yeah, I'm just saying the background, ma'am. What is the cause and how it is?
No, we all know that. You can go back because time is already.
Okay, ma'am. Okay, ma'am. Yeah. So yeah, the aim is that we are going to study this conformational changes of collagen in oral submucous fibrosis. The objective is we are going to isolate the human oral cavity native collagen from a normal and an OSF patient, and we're going to study the structural changes in a normal patient and an OSF patient. So the methodology is we are going to take the samples from normal and the OSF patient, and then for the OSF patient, you have to take all those Aricanet showing histories and then doing H&E staining to this. After this, the tissue is stored, transported, and processed as per the protocols. And we're going to use X-ray crystallography. I'll just say what is X-ray crystallography is. We're going to see this collagen structures in a molecular level by striking a beam of light, and we are going to see the molecular structures in the collagen, with which we can study the structural changes happening in the OSF patient from a normal patient. So these are the parameters we are going to see, like hand helix pattern, fiber diffraction pattern, fiber period, and helical symmetries. So with the data obtained with this, we will differentiate what is the structural changes happening from a normal and with an OSF patient. So what is the implication when we untreat this OSF? Because it has a high risk of transformation to oral cancer, because this is a pre-malignant condition. It is not a malignant condition. If left untreated, it may lead to an oral cancer. So understanding the confirmatory deviations of this collagen and OSF from normal, it will help us to elucidate the molecular structural changes that the disease process involves. So this will facilitate to conceptualize and design a novel treatment for a patient. So what is over many centuries is very hardly recognized and poorly understood across the globe. So better integration of both medical and dental services, especially in developing countries, may reduce this patient suffering and improving their life qualities. And all those healthcare professions must have to work together in this public education and primary prevention to treat people easily. So see, this is the thing, because this needs to be taken into consideration, because more and more people are getting addicted to areca nut suffering of OSF, especially in the northern parts of India, because the availability of chuka, that is areca nuts, is more prevalent there. And the main cause of me doing this project is this case hated me a lot. 14-year-old girl, she was suffering of burning sensation and was diagnosed with OSF. So the history presents that she had been having this habit of chewing this twice to reduce the anxiety and to get relief from pain, because she had been working as maid in some houses, and also highlights that the threat of ready availability of those flavored areca nuts to young children in markets at low cost. So this results in threatening pre-malignant condition. So government has to take this into consideration and reduce the availability of those areca nuts to even young children. And this also emphasizes that young children are getting into depression and anxieties, and to get relief from this, they are moving on with this habits of chewing areca nuts and more drugs today. And my summary is this: use of this research through X-ray crystallographies is in order to treat more people out of this, because collagen's role is in OSF is the key made out for this research work. So in this part of presentation, I make an awareness not to consume more of areca nuts and be preventive as much as possible, because even though we have conservative therapies, HBOs, dexamethasone, we have more and more drugs to treat this. But moving on with drugs, it's rapid onset of, and then it's a time to act in our body. We can more first different collagen structures and then spring the drug use. Thank you for me to present this topic. Thank you, ma'am.
Yogita, short and
Yes,
sweet
ma'am.
presentation. But I need to
Thank
know
you, ma'am.
two points. One thing, H&D pictures. Have you shown the H&D pictures and analyzed with the pathologist?
Ma'am?
Have, can you hear me?
Yes, ma'am. Yes, ma'am.
Have you got a score of histopathological analysis from a
Ma'am,
pathologist?
no, ma'am. Just we are starting this before a month. So with my professors in oral pathology, we started this. So we are just making out patients and getting through this, ma'am. It has been only a month starting this. So in a couple of months,
How many cases you have got?
Ma'am?
How many cases you have got? The
Ma'am,
sample size?
for now, we have taken about 3 patients from OSF, and we have got 2 normal patients. We have to get those biopsies and staying, and then we have to move on with this crystallography, ma'am. This is completely a biochemical study, because not only with going on with medical, we can go for biochemical studies, ma'am, because that may help us get out easier treatment plans in this OSF, ma'am. Even though we have all those conservative therapies like oxygen therapy, dexamethasone like drugs we use. While viewing the collagen structural changes, we can design drugs for that. And we can see the prognosis happening in the structural changes, ma'am. That is the main
Okay.
emphasis for this research.
Any scoring was done in X-ray crystallography also?
Ma'am?
Scoring any qualitative analysis has been done or qualitative analysis has been
Ma'am,
done?
yeah, ma'am, we are just moving on in that, ma'am, because it's only a month we have started. So I got this opportunity to
Okay.
present this year. So we'll be doing
Okay.
this in the next couple of months. We'll be completing the project, ma'am.
Okay, thank you.
Thank you, ma'am.
Yogita,
Yes, ma'am.
your intent is good. You
Thank you, ma'am.
took this platform to present what you have proposed the study,
Yes,
but
ma'am.
for I mean platform, I don't this is presentation what you have
Thank you, ma'am.
proposed. No, you should have presented after your results are out. So
Yeah,
that's what I
ma'am.
was also confused of. Your aims and objectives are different, and at the end, your conclusion and all that is just a general statement that you had made.
Yes, ma'am. Yes,
So
ma'am.
you should wait for the study to complete and then present.
Yeah, ma'am, of course, ma'am. But I got this opportunity because it has been designed and it is on work. So I got this opportunity. So I went on with this, ma'am.
Okay.
With the help of my professors, ma'am, because I got a permission from my professor and he said, yes, you can. And with this help, I made this, ma'am.
Okay. Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you, Yogita. Next, I would like to welcome Kumar Rajkumar. Is studying third year.
Is my screen visible?
Yes.
Good evening, respected judges. I'm Hamrish Kumar Rajkumar, a pre-final year MBBS student, here to present my research on assessing the use of triglyceride glycemic index (NLR) and PLR and distinguishing between a malignant. We'll go through the introduction, the objectives, the materials and methods used, results, discussion, conclusion, and finally references. So, as you all know, breast cancer is one of the most common malignancies that causes mortality and morbidity worldwide. And in India, it is the first and the most common cancers diagnosed. So, the main difference between benign and malignant tumors is that tumors are localized to the site of origin and they can be treated by surgical removal, whereas malignant tumors tends to metastasize. So, the common clinical features of breast cancer are swelling, skin dimpling, breast or nipple pain, retraction and discharge, and swollen lymph nodes. So, according to this, malignant cells utilize glucose in preference to other metabolites so that through the process of glycolysis, they are able to create skeletons for like rapid division. And in cancerous cells also, there is reduced need of energy. So there'll also be the loss of mitochondria, which leads to less beta oxidation in cancerous cells, leading to accumulation of triglycerides in the body. Neutrophils also forms the neutrophil extracellular traps, where the neutrophils extrude their nucleus in the microenvironment of the tumor, and so that they capture these metastatic cells and prevent the metastasis. And platelets also have a role in hemostasis and thrombosis, and it has an interrelation between neutrophils. So these were the primary reasons why we made an hypothesis of TYG index, NLR, and PLR in trying to distinguish between benign and malignant lesions. So our objectives was, first we derive correlation between the TYG, NLR, and PLR in characterizing a breast mass, and then later on we derive cutoff values to distinguish the nature of breast mass. So after we obtained the Institutional Ethics Committee approval, we designed a cross-sectional study where we included patients reporting to the OPD of surgery with chief complaints of breast mass. So our inclusion criteria was that we selected all female patients who had reported to the OPD with chief complaints of breast mass, and we excluded diabetic patients, patients with a history of familial hypercholesterolemia, platelet disorders, or any sort of infections. We explained the study protocol and then obtained the written informed consent, and then clinical examination of the breast was carried out, and a history is collected and is collected in a proforma which we designed for this study. Then FNAC is carried out with the aid of a 22 gauge needle, and cytological analysis is used to characterize the mass as benign or malignant. When the patient comes to collect the report 3 days later, That time we asked the patients to come in a fasting state where 2 ml of blood was collected in a red, purple, and gray vacutainer to perform the CBC, serum fasting glucose, and serum triglycerides biochemical investigations. So these lab values were entered into Microsoft Excel for data collection, and then we calculated the NLR, PLR, and TYG index according to this formula, which is present here. The breast mass was then subjected to biopsy, either a true cut or an excisional biopsy for a histopathological examination to confirm the diagnosis that we got from the FNAC. And then all the data was entered into Jamovi software for statistical analysis. So our study consisted of 200 participants where, like after accounting for attriation, so we had 110 benign breast mass cases and 90 malignant breast masses. And the mean values of NLR, PLR, and TYG are represented in this table. So from this, when we ran a Mann-Whitney rank-sum test, we see that there's a statistically significant difference between benign and malignant for all except for NLR. So, in TYG index, we found that malignant breast masses had a higher TYG index than benign breast masses, and PLR was elevated in benign cases than malignant cases, and NLR had no difference. So we then plotted an ROC curve, and the cutoff values for TYG index was found to be 8.823 based on the highest Unden's index, with a specificity of 94.4% and a sensitivity of 90%. So over here, I have the ROC curve plotted. We did not plot an ROC curve for NLR since there was no difference. And we plotted an ROC curve for PLR, keeping benign as the positive class. And we found this as the ROC curve. And the cutoff value was 88.4, with a specificity of 76.67 and sensitivity of 75.45%. So currently, the diagnostic guidelines for diagnosis of breast cancer will be first be the either the clinical breast examination by physician or the self breast examination, followed by diagnostic mammography, and then it is all confirmed. The gold standard confirmation is by biopsy and pathological opinion. However,
Sir,
this
time's up.
So, can I take 30 more seconds to complete?
Okay.
Hello?
Okay, Amrish Kumar. Hello.
Yes, ma'am.
Okay, this is a good study actually regarding the malignant and benign breast masses. You got 200 as a sample size. Anush.
Yes, ma'am.
Okay. Is there any missed data you got? Because all the 200 patients
After
got,
this was 230 not reporting with fasting, or some of them like we could not follow.
yeah.
We expect removing the attrition only, ma'am. We got 200 as a final.
200 as a final. Okay. Okay. NLR, there is a difference, but it is not significant, isn't it, statistically?
Yes, ma'am. NLR, it's not significant statistically. Like we cannot create guidelines for distinguishing benign. Like for TYG index, we can say that if the value of TYG is more than 8.823, we can like say with some surety that it might be malignant with a sensitivity of 94%. But for NLR, we cannot derive any such conclusions.
Okay.
And PLR, even though it is like higher in benign cases, the sensitivity and specificity was low. So in future, we may be able to design a criteria which involves both TYG and PLR, which will increase the sensitivity further.
Okay. So what may be the reasons for these exclusion criteria, diabetes mellitus, familial hypercholesterosis?
TYG index is actually a surrogate marker for insulin resistance. It's a proven surrogate marker for insulin resistance. So all diabetics will have some form of insulin resistance, and if we include these type of patients, like our study, like the TYG may be like falsely elevated even in some benign cases. If there is a benign breast mass with who is a diabetic, this might be falsely elevated. That's the reason we excluded them. And infections and platelet disorders, they alter the NLR and PLR values, ma'am.
Okay, hypercholesterolemia?
Triglycerides, ma'am. Hypercholesterolemia or triglyceride values will be falsely elevated.
Okay, thank you. Over to you.
Thank you, ma'am.
Very good, Amrish. That was a very interesting topic. I too had the same question. Why did you choose such exclusion criteria? Because, like, all those are also proven risk factors for malignant tumors.
But in specific, like our thing was to create like a diagnostic differentiating tool, ma'am. Like not something that led to the pathogenesis. It was not like something that calculated the risk and whether this patient having a breast mass will have malignancy or not. A patient who already had malignancy in a PHC where diagnostic mammography is not available, but all this like simple blood investigations like CBC, serum triglyceride and glucose is available. Like at the PHC level, we'll be able to just make a small like one small blood investigation and calculation, and we can easily refer like some patients will immediately refer, okay, this may mostly be malignant.
That's
And
what this methodology. But the problem, I mean, my doubt was about all those are proven risk factors. So you exclude that, then we exclude. Uh, so maybe you can try with a larger sample size, and maybe even your LR can come out positive if you include if you do this in a larger sample size. So one of the suggestions from me.
okay, ma'am, we'll try to incorporate that.
Okay. Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you, Amrish. Next, I would like to welcome Varsha Satyabal, studying third year from Government Omandurar Medical College.
Good morning to the judges and fellow participants. Is my screen visible now?
No, screen is not visible.
It's taking a moment.
Yes,
Is it visible
yes.
now?
Yes.
Good evening, everyone. Myself, Varsha Satyabal. I'm a pre-final student, and I'm going to present my research on the topic the predictive role as indicator and lymphocyte ratio and the platelet lymphocyte ratio, determining the prognosis of patients with coronary syndrome. The table of contents that we will be discussing today. Let's dive. Infection, which is the most leading cause of mortality and mortality in India. For general statistics, I want to mention there was a study which says that the of infraction India is
Varsha,
currently
your voice is breaking.
audio.
Yeah, it's now also it's breaking. Kindly check.
Is it breaking still, or am I?
Yeah, it's okay now.
Yeah, is my screen visible?
Yes.
Yeah, thank you. Yeah. So, acute coronary syndrome, it refers to the group of when it mediated sites and monocytes, they get recruited in the particular includes when a patient comes with the symptom of ischemia, when a patient has an ECG changes, or when an imaging study confirms that there is a or
Varsha, we're not able to hear you at all. Your audio is very poor.
Varsha, your
Maybe you get
voice is
yourself
breaking
ready.
again.
Let her get herself ready. Maybe we can go to the next presenter. Come back to Varsha.
Ma'am, can we go to the next participant?
Yes, ma'am. We can have the next participant.
Yes, ma'am. Okay, so I would like to welcome Swati GS, studying final year in Vinayaga Mission, Shankaracharya Dental College.
Hello.
Hello, Swati, you're audible.
Yes, ma'am. Can you give me a moment to share my screen, ma'am?
Yeah.
Yes, ma'am. What is the reason for any delay in the presentation?
Ma'am?
Are you able to see my screen, ma'am? Like I started doing my screen sharing, ma'am.
No, screen is not visible.
Okay, ma'am. 1 second, ma'am. Ma'am, I think I'm having a technical issue. Can you just can you just share the screen, ma'am, for me?
Ma'am, previous presenter is ready. I hope so. Can we ask her to present, ma'am?
Is a network issue is rectified?
Yes,
Your voice
ma'am.
is clear.
Swati, are you ready?
Is Varsha ready?
Varsha, are you ready with your presentation?
Yes, ma'am. Am I audible now?
Yeah, you can
Clear?
start.
Yeah, thank you.
Varsha, leave out the introductory part. Go to your aims and objectives, methodology, and the results and conclusion.
Okay, ma'am. Objectives of our study was to find a correlation between the NLR-PLR values of patients who are been diagnosed with acute coronary syndrome and assessing their prognosis using the GRACE scoring criteria. And our second objective was to propose that the systemic inflammatory response index, which is SIRI, which is a novel inflammatory marker that can predict the prognosis of acute coronary syndrome patients. Coming to the materials and methods of our study was designed to be a retrospective cross-sectional study, and the study setup was the Department of Medicine and Thai Ward of Government Medical College, Omandura Government Estate, and we included patients who were diagnosed with acute coronary syndrome according to the ACC guidelines, and we excluded patients who had other inflammatory disorders. Those conditions that could influence the NLR, PLR, and SARA index values, and the case sheets of these patients were assessed from the MRD to calculate the GRACE score of the patient. Now, this is which the GRACE score. It is a standard scoring system which is commonly used in the US for assessing the prognosis of acute coronary syndrome patients. And in using this score, the in hospital prognosis and also post discharge to 6th month to death prognosis of patients can be assessed. This scoring criteria, it includes the age, the heart rate, the systolic blood pressure, the class, creatinine levels, and the laboratory investigations like the cardiac markers. Also, the ECG changes are also a component of this scoring system. The data obtained for our study from the case sheets were the CBC reports of patients, the age, sex, ECG, the cardiac enzymes, and all those components that were required to obtain the GRACE score of the patient. And for the calculation of the SIRA, NLR, and PLR values, the formulas that has been displayed in the slide were used. And the data obtained here was entered into Excel sheets and it was exported to Jamovi software for statistical analysis. The study consisted of 250 participants, where males were 153 and females were 97. Pearson's correlation was used, and there was a significant correlation between the NLR, SIR, and GRACE criteria. PLR showed no significant correlation. And while comparing the correlation between the NLR and SIRA index, SIRA had a much stronger correlation with the GRACE criteria rather than the NLR. So from this, what I want to conclude is that SARA, it can be used as an add-on tool for estimating the prognosis, the in-hospital prognosis of patients who are affected with MI, because the current GRACE scoring system is only used in US or the other countries, while in India the current criteria for assessing the in-hospital prognosis of MI patients is just we take a repeat ECG of the patient and we clinically monitor those patients. But using this simple CBC report or the SIRI index, this can help us to get an outlook or idea of what under which risk category the patient actually falls into, whether he has a low risk, intermediate risk, or high risk. And also, this can be used as this can be added to a clinical decision making tool where the CBC report can be obtained in minutes, whereas the GRACE score, which takes 1 to 2 hours to obtain because it consists of more laboratory values and the cardiac enzymes. Thank you, everyone. 1 minute. I also want to mention the strengths and limitations of our study. The strengths of our study is that SIRA, it is a useful indicator and it is time conservative and not much calculations is involved here compared to the GRACE criteria. And also later stage MI, patients present with a late stage of MI can also be detected because monocytes is
Time's up,
also
ma'am.
involved. monocytes is also involved in the SIRA index, whereas the normal CBC, which where they also calculate the NLR and PLR, it usually contains only the neutrophils and lymphocytes. Monocytes, it is a component of a late stage of inflammation. So patients who are late stage MI can also be detected by this method. And the limitations of our study is that the study was conducted retrospectively, and the patient follow-up was not possible. Hence, the post-discharge prognosis of the patients cannot be assessed by this study. Thank you, everyone.
Varsha, this is a good study design you have chosen. And I need to ask two questions to you. One, what is the part you had?
Ma'am, we compared the prognosis of patients using the GRACE criteria, GRACE scoring system, which is a
This is
standardized.
acute. Wait. Acute coronary syndrome patient you have taken as a sample, and who are the controls? Are you have any control group or not?
No, ma'am, this was not a case control study, ma'am. This is a cross-sectional study that was
Okay.
designed.
Okay.
And with this
How will you
cross-sectional study,
calculate
we
the prognosis with
using
that?
using the GRACE
NLR
scoring criteria.
ratio, if it is, yeah. NLR ratio, if it is this much, it is mild prognosis, and that is good prognosis. Like if it is increased to how much, and how you can compare it, how you can
Ma'am,
assess. Is
normally
there any? Yes, tell me.
Ma'am, the normal values of NLR is from 1.2 to 4. It is considered as normal, ma'am. So patients who had values higher than this can be suspected, or the patients who come with chest pain or symptoms of angina, or patients who have ECG changes, and if they have a very higher value of SIRA index and NLR, we can have a suspicion that this patient falls under high risk category.
One more thing. With the acute coronary syndrome, if the patient has any other systemic illness, acute systemic illness or inflammation, it will be altered. The NLR and the PLR ratio can be altered, isn't it? Did you
Yes,
exclude all those persons from your study?
yes, ma'am. Those conditions which alter or which has an influence on
Mm.
the NLR, PLR, SIRA index, those patients were excluded from our study. And here we three values, and on those three, SIRA was found to be more significant rather than the
Is
PLR
there
and
any
NLR value.
peripheral smear? Is there any peripheral smear comparison done to count the differential count to know the monocyte count, exact monocyte count?
No, ma'am, there was no peripheral smear examination done
Because for
because
all the patients in the CBC report, we can't get the monocyte value. It can be eosinophils and the monocytes. It are now sometimes it will go for zero also. Okay, understood?
yes, ma'am. But in our CBC reports, we also had their differential counts. So with that, we calculated these values, ma'am.
So those are all 250 patients. You got the monocyte count also.
Yes, ma'am. Yes, ma'am. With the CBC report,
No
we also had.
missed values, missed data, or nothing else.
Ma'am, initially our sample size was 265. We had a confidence interval of 95, and the prevalence of MI in India was found to be 650 with the in 10,000
Okay.
populations. So we did this study retrospectively. So we came under many CBC reports, which were the print of the CBC reports were just erased due to the time as it
Yes,
went on.
yes.
So initially it was 268. So later we only had 250 patients whose CBC reports with the differential counts were
Okay,
available.
as it is a retrospective study, my suggestion you can have a control group to check whether it is possible to compare the control group's NLR ratio and the acute coronary syndrome. That will be more beneficial than the single cross-sectional study. Okay.
Okay,
Over
ma'am.
to you, ma'am. Thank you.
Yes, Varsha, interesting presentation, but taking forward from Vrinda ma'am, yeah, I also have the same opinion. This was a retrospective study.
Yes,
Uh,
ma'am.
so you had compared your SIRI with the gray score.
Yes, ma'am.
I mean, the cardiac enzyme markers were available for all patients for you to do the gray scoring.
Yes, ma'am. To diagnose or to categorize a patient has MI, all the cardiac enzymes and the ECG was taken for those patients for actual diagnosis of MI or acute coronary syndrome.
So all those were available in the case sheet in your MRT department.
Yes, ma'am. Yes, ma'am. They were available.
Okay, if that is available, then gray score is. I mean, we do cardiac enzyme markers for all patients who come with chest pain. So that is the first thing that we do. Any hospital, private, government, anywhere. Anyone comes with a chest pain, the first thing that we do is look for the enzymes. Trop test is what is done. So what is the
Ma'am, not
advantage of?
only. Yes, ma'am.
So what is the advantage of SIRI over gray score?
Ma'am, not all patients who come with a mere chest pain, we check their cardiac enzyme markers, or an ECG can be done if the patient comes with a precordial pain. But if the patient also complains of chest pain along with palpitations and pain radiating to the arm, those patients who have clinical symptoms of suspicion of myocardial infarction, for those patients, the cardiac enzymes and ECG is taken, ma'am. But
Hmm. Yes.
for example, in a list setup, CBC mints are available. So in that we can actually get the NLR, PLR, and SI indexes. And also when the patient is to the hospital and if he is diagnosed with an MI and he is admitted to the hospital, to check the prognosis of the patient or whether he is responding to the medical intervention that's provided to him, we can actually get their CBC reports and check for these blood parameters, and with that we can get an overlook of how the patient is responding. For example, at day one, when the patient was admitted, his SIRA index, NLR, PLR, and after the medical intervention, his blood levels of
That's
that
what I
can be
understood.
checked.
I mean, I understood you can do a CBC now and then, and you can do your SIRI scoring. But what I mean to say is, gray scoring can also be done, which is a much validated score used worldwide.
Yes,
So
ma'am.
I don't understand. I mean, this is okay. We can predict using SIRI. But what is the advantage of SIRI over GRACE is what I want
Ma'am,
you to
because
explain.
yes, ma'am. Yes, ma'am. Grace scoring system, it has more components associated with it, and also the calculation part and the time required to obtain a Grace score, it takes minimally 1 to 2 hours, but a CBC report can be obtained within 5 to 10 minutes. So the time factor, and also a Grace scoring system cannot be done in an ambulance setup or in a PHC setup, but a CBC machine is available both in the ambulance and also in a PHC setup. So I
No,
guess it
No,
is.
PHC has got
CBC will
ECG
not
and
be
the
available
cardiac
in.
markers.
Sorry.
All are available in the PHC. So,
Yes, ma'am. But the time required to get them, or the time required to put the grace scoring system for the patient, is what the concerning factor. Yeah.
okay, okay. Thank you.
Thank you.
Thank you, ma'am. Thank you, Varsha. So we have our last presenter, Swati GS, studying final year in Vinayaka Missions Dental College. Swati, you are muted. Can you unmute yourself?
Thank you, ma'am. Good evening, respected chairpersons and all my dear delegates for here. I'm Shwati from Vinayaka Mission Shankaracharya Dental College, a final year student. Ma'am, Moshita, ma'am, can you just share me the PPT, ma'am? So good evening, everyone. So my topic is an interesting topic, which is about liquid biopsy. I've done a research with my professor from the Department of Oral Medicine and Radiology. So to begin with, Ma'am, can you just keep changing, ma'am? The next slide, ma'am. Okay, ma'am. So I'll just begin with that, ma'am. So the contents for my presentation would be the introductory part, the CTC deduction, the cfDNA, exosomes, conclusion, and the references. So to begin with the introduction, everybody are familiar with the word biopsy, which is the solid biopsy that we take a tissue which is taken from a living body, and then it is sent for the pathologist to examine or to check if there is any histopathological changes and development of the cells in the tissues. So this is what solid biopsy is all about. But this is more, it hurts patients, and we need to do the incision and proceed with a solid biopsy. But whereas the liquid biopsy we would be doing in a minimally invasive technique, which was not going to hurt the patient as well. So to begin with the CTC detection, which is the circulating tumor cell detection. So in the year 1860, Ashworth, they were doing a study with the peripheral blood smear. So in that blood study, they found that the CTC cells, circulating in the bloodstream. And then they took this and they started working on with this. So with this help of the circulating cells, we can mark the certain cells like lysosomes and all, and then proceed with the findings, ma'am. So this would be the first step. And the second step would be the CSF DNA, which is the cell-free DNA. This also can be marked with the help of ethylene diamine tetraacetic acid. So these cells also can be marked, and then it can be sent for the for the studies. And moving on to the exosomes, they are the vast cells in the body, and exosomes not only present in the blood, but also they are seen in mucosa, and also in cerebrospinal fluid, everything. And also it is seen in urine also. So this kind of fluids, it can be centrifugated, which is a most widely used method. So the centrifugation can be done, and cells from the exosome cells can be they can be segregated from the centrifugation method, and it can be sent to the ultra centrifugation method. And using the methods like CAM technique and CD326 technique, we can just find out if there is any development in the tumor cells, ma'am. So to conclude with, yeah, we being as the doctors, we might or we will be encountering many patients with tumor development. So when we send a patient to the radiation therapy, we would just wait for the results and send the tissues, not only in the field of tumors and all, even in the the renal failure cases also, ma'am. We send the pieces of kidneys, some tissue from the kidney, and then we send it to the pathologist. So they wait until the results, which is sometime it is cost more more high. But in the point of liquid biopsy, it is less expensive, and we can be doing it even when the radiation therapy or the treatment is going on. We can do it how many times we want it, ma'am. So I think this would help the people out there. Me and my sir, professor, we have published an article about this, and it has already published, ma'am. I think, yeah. So to conclude with, I think this topic has found an interest in you all. Thank you so much, ma'am. Thank you, everybody.
Moticha, can you just run through the slides?
Previous one. Motisha? Actually, Swati, our presentation is short and sweet, and actually already the liquid biopsy techniques, all those things are there in the current diagnostic techniques also.
Okay, ma'am.
Okay.
Yes, ma'am.
So this is actually not a new one,
Yeah.
and it is more costlier than to identify the DNA level than the histopathological analysis.
Okay, ma'am.
The patient won't afford, and in liquid biopsy, the cells of the malignant cells which can't be differentiated from the
Yes.
normal cells. Somehow it is like not like histopathological orientation we can't get in the liquid biopsy.
Yes, ma'am.
Okay.
Yes, ma'am.
As a young budding undergraduate, I think this is a new topic for you,
Yes,
but you
ma'am.
need to work up in this for wholeheartedly. And if it is a comparative study or any sample analysis, this will be useful also for the future.
Yes, ma'am. I
Okay.
look forward for it, ma'am. And yeah, ma'am,
Yes.
as you told, like, yeah, there are some disadvantages from this also, ma'am. But thank you for your concern, ma'am.
Yes. Thank
Yes,
you,
ma'am.
ma'am.
Yeah, thank you, ma'am.
Yes, Swati, like you have proposed something as a new technology, which Madam said, who's a pathologist herself, like this
Yes, ma'am.
already, I mean, this liquid biopsy is already in vogue. Maybe you could try out some studies and then give us a
Sure, ma'am. I
comparative,
will.
yes,
Yeah, ma'am.
study
Yeah,
report. Thank you.
thank you. Thank you.
Thank you, Swati.
Thank you.
Thank you, ma'am. Ma'am, first I would like to call upon Brunda ma'am to give a feedback and her positive views.
Actually, I think most of the interns, as your level grown up, you people are doing good at research also. Like third years are presenting with NLR and CBSE values. All those things are very good to see. And at an intern level, I have done very good animal model study. So these are all actually you people are very much interested in the research, and you are started. Some of them are just started their research. So I congratulate all you people, and you are all presented very nicely. At your age, I can't even think about the presentation at this stage, and you have a firm in with Student Network Association, and very good organizers are there. And I hope it will be useful, and our suggestions also useful to you. And all the best for your future. Thank you so much.
Thank you, ma'am. Next, I would like to call upon Chitra ma'am to give her positive feedbacks and reviews.
First of all, congratulations to all the presenters. As Madam said, all of you have shown so much interest in research. So keep up that spirit, and we would like to hear more from you as researchers, and all the support from all of us for you to continue your scientific research work. So congratulations, all of you.
Thank you, ma'am. Thank you for your positive words. Next, I would like to call upon Yuvasri to give vote of thanks.
Good evening, all. This is Yuvashree from PSG Institute of Medical Sciences and Research. We would like to thank each and everyone who participated in this event, and we extend our heartfelt thanks to our esteemed judges. We are truly fortunate to have you, ma'am, and thank you for dedicating your time and knowledge to assess our work. Thank you all.
Uh, Thank you, Yuvasri. I would like to personally thank Brinda ma'am and Chitra ma'am for taking the responsibility of judging this event. Without you, this wouldn't be possible, ma'am. Thank you so much. And I would like to thank the participants who were constantly being in touch and they have done their best. So we'll announce the result probably in 2 to 3 days. So thank you all. Thank you for this event. Thank you.
Thank you, ma'am.
Thank you, Motisha and Bala Hariharan.
you.